Thanks for being with us. My name is Jason Starr. I'm a medical oncologist at Mayo Clinic in Jacksonville, Florida, and I am thrilled and honored to be here with Dr. Pamela Kunz, who is an associate professor of internal medicine and medical oncology at the Yale School of Medicine. She's also director for the Center for Gastrointestinal Cancers and the chief of GI Medical Oncology, and one of my valued and esteemed colleagues, and a member of NETmed for some time now. So thank you for being here with us this evening, Dr. Kunz.
Thank you, Dr. Starr. My pleasure.
So this video chat is going to be in regards to an ENETS presentation that you had, and I found very interesting. I think our viewers will also find it interesting, on the sex differences in patients with neuroendocrine neoplasms. So I wanted to kind of start off and ask you just generally, as it pertains to neuroendocrine tumors, could you highlight some of the epidemiologic differences in sex as it relates to diagnosis and outcome?
Sure, I am happy to do that. And what I might briefly do also is just sort of a why this matters. And we may get to that also, but I will claim no real expertise in this area. I've gathered some interest in this over time as we're starting to see real differences by outcome and sex in other diseases. I think something that was really highlighted for me was in COVID, where we saw differences in outcome between males and females. Also, just a definition is that we're talking specifically about biologic sex. I think gender is something that we also sometimes talk about, and often they're interchanged, but sex is a biologic construct and gender is really more of a social construct. And so there are some key differences in between males and females in neuroendocrine neoplasms. I'm drawing from one of the large SEER studies from Drs. Yao and Dasari and others. And there are really key differences in terms of incidence by primary site, by sex. For example, patients with lung and stomach and cecum and appendix NETs are more common in females. Thymus, duodenum, jejunum, rectum, and pancreas are more common in male patients. The other thing that we sometimes will see is that males are, from these epidemiologic studies, males are more common to have metastases at presentation, and females often have longer overall survival. So all of this to say that there are key epidemiologic differences.
Yeah, those are fantastic to highlight, and it creates a lot of questions and hypotheses of why this could be. And I'm really glad that you're highlighting this. It's something that I think, as you alluded to, is understated and understudied, and is critically important that we identify that males and females are different and appreciate those differences and study them and learn. So thank you. So another question that I wanted to bring up is, of the NET trials that have been done, and in your presentation broke down beautifully kind of the male and female, preponderance in those studies. What jumps out at you in regards to those differences? Anything kind of triggers some thoughts about that?
So for the viewers, I tried to look at some of the key big randomized studies to look for some patterns. So those included the studies of lanreotide and everolimus and ludotatate. And I'd say one of the biggest take-homes is that they really didn't look at sex or outcome by sex. So I think that per your earlier point, we actually have a lot of work to do. They did include sex in their table 1. So for most of those studies, we know the breakdown by sex. And what I found really interesting from that is that there were imbalances both between the arms and within the arms. So then that raises the question, can we really generalize the results by sex? And I think we just don't know. Not all of the studies, but some of them included a forest plot with sex as a subgroup analysis. For most of those studies, patients male and female patients together both benefited. I will highlight that in the RADIANT-4 study, male patients, the standard deviation bar for that forest plot crossed 1. So male patients perhaps did not benefit as much as female patients in RADIANT-4.
Very helpful. Thank you for those observations. And then and you included in your presentation, it was a abstract that I believe was from ASCO, and it was it was a retrospective analysis from Moffitt Cancer Group, and they looked at CAP-10, and they tried to look at sex-specific AEs, and they had some really interesting observations. Can you elaborate on those a little bit?
Yes. In fact, this was one of the studies that really I thought was thought-provoking and made me actually question some of these sex differences. I thought it was super interesting. So congrats to that study team for really flagging this. So what they found in a study of over 400 patients, it was a retrospective study of patients treated with temozolomide-based regimen with neuroendocrine neoplasms. They found differences specifically in cytopenias between male and female patients. So female patients had twice the risk of having low platelets and had about 5 times the risk of having low neutrophils. And so, I thought that was really striking and not something that I've paid attention to in my own population. So it's interesting to think about what the clinical implications for that might be.
Yeah, I was fascinated. I thought, could there be some pharmacogenomic aspect to it? And, in terms of metabolism, we know that there's definitely different metabolism in the liver and gender, male and female. And then, question would be, would you maybe potentially monitor female patients a little differently than males while on that therapy? Maybe you would check, labs normally, maybe, every 2 weeks, every 4 weeks. Do you think it would change your practice at all?
It's a great question. I think we don't have prospective data yet. And I think this is my plea to all clinical trial researchers that we need to actually include sex as a pre-planned variable as we're looking at our outcomes, both in terms of efficacy outcomes and adverse event outcomes. And I think that, when we first learned that right versus left-sided colon cancers were different, this was this sort of aha moment. And I think this is another one of these really simple, basic questions that has not been studied enough.
Yeah, a lot of assumptions, but not a lot of data to support those assumptions. And then one final question, this has been great. Do you think clinicians at this point should tailor their approach to patients with NETs based on gender in any different way?
I think we're not quite ready for that. I think that I suspect that there are, real differences in terms of efficacy and in terms of adverse events. I'm really eager to both personally start incorporating that into my research. I hope others are as well. And so I think we're not ready to make those changes, but I'd encourage even just treating physicians to be looking for patterns. Are your female patients, particularly with CAP-10, since we have a little bit of preliminary data on that, do they respond differently? And stay tuned. I hope we have more answers next time.
Terrific. Well, this was wonderful. Thank you, Dr. Kunz, for sharing your hard work. And we look forward to, future studies, including your work to, further, hammer out these differences and learn more. So thank you.
Great. Thank you.